Hey, welcome. This is Chapter 1, Brief History of Athletic Training. This comes out of Chapter 1 in the Arnhem, used to be Arnhem and Prentice, now it's just Prentice textbook. But in today's lesson, we're going to take a look at how the profession got its start, some of the milestone moments in the profession, and what we can hope for in the future. We will also take a look at legal concerns and insurance issues, but we'll do that in another screencast just to keep the file size down. So for this week, we do have these two lessons. Ordinarily, we just do one, but make sure you check out that other lesson as well. So the PowerPoint for this is available on the course website, so make sure you check that out. If you don't have that yet, I'd go ahead and pull that off, print it, and jot notes on it, or if you want to jot notes on your device, you can jot notes on the PDF and do it paperless. So either way, that's good. So what we see here is an example of athletic training in the 50s. This gentleman is a quote-unquote trainer, not necessarily a certified athletic trainer. I believe this is from the archives at Texas Christian. You see him taping basketball player's ankle here. You see an assortment of liniments and topical whatevers. But what we know is that the profession has certainly changed dramatically from those early years. So we're going to take a look at that today. Now, athletic training as a profession is a relatively young field, but we know that if you were to take a look at what it is ATs do, you could actually make the argument that ancient Greeks actually first invented the profession. Massage was used for Olympic athletes. If you notice here, a couple of Olympic wrestlers participating without the addition of their singlets like we would see in the Olympics today. But massage and various preparation for athletic competition was pretty common in that culture. But in all honesty, athletics and athletic trainers specifically didn't really reemerge until the 19th century. And gymnastics at the time was kind of the sport of choice in the mid-1800s. And then with the advent of college athletics, which really didn't start until the later 1800s, post-Civil War era actually, team sports started to get more popular in American colleges and universities, and it became clear that there was a need for a caretaker to manage injuries, prevent injuries, and overall assist with the athletics program in general. So athletic training as a college level profession really got its start in the Ivy League, kind of the birthplace of college in general and college athletics specifically. In 1869, Rutgers and Princeton played in the first college football game, and by the early 1900s there was actually a push to make college football illegal. So President Teddy Roosevelt at the time was threatening to abolish football entirely and outlaw it as a collegiate sport. The very first athletic trainer who had that title of trainer, and I use that with air quotes, and we'll talk about why in a little bit, was hired in 1881, and Yale followed shortly thereafter with Michael Murphy around the same time. He later went to the University of Pennsylvania, but the profession as a thing at the college level got its start before the 1900s. Okay, Dr. Samuel Billick is widely touted as the father of athletic training, and he started as what he referred to himself as a student trainer at the University of Illinois when he was pre-med, and he helped out with the various athletic programs. And in 1916 he published a book called Athletic Training, which was later turned into the Trainer's Bible. This was really the first textbook we ever saw devoted exclusively to the profession of athletic training. Prior to that, maybe emergency medicine related medical books, but those were intended primarily for physicians. If you've been around athletic training any at all, maybe you've gotten your ankles taped or bought a brace or something like that, the name Kramer might be familiar to you. It's still in existence, still being manufactured and produced. And that company got its founding from brothers Frank and Chuck Kramer, who started out in Kansas in the 20s, and they manufactured a liniment that they sold to athletic teams around the country eventually. They got Newt Rockne to buy some of their liniment, and once the University of Notre Dame was on board, their company really grew from there. They started a series of workshops called Kramer Clinics, and they were actually part of the medical team that serviced U.S. athletes at the 1932 Olympics. They started publishing basically like a brochure, a periodical that went out called The First Aider, and that was actually still in production as a paper mailer until just a few years ago. I believe that's still produced as an online resource, but that got it started in the 30s. And the Kramers were really the first to kind of organize this loose collection of people who were operating at different colleges and universities around the country. And when I say colleges and universities, it was almost there exclusively. There were no athletic trainers in private business operations or industrial settings. There were no athletic trainers at the high school level. Nothing like what we see today where they work in physicians' clinics. These were single white males usually, with very few exceptions, who were laboring all by themselves without any kind of network, and they were all kind of doing the same thing, but they were doing it in isolation. This is a pre-internet era, so it wasn't like they were sharing tips and tricks with one another via Facebook. They were very much building the profession one little isolated pocket at a time, and it was the Kramers' idea to get this band of folks doing the same thing together and form the very first ever National Athletic Trainers Association. So the first NATA came about in the late 30s, 1938 to be specific. Topics at the time included treating Charlie horses and using heat lamps. Here we see this is Babe Ruth being rubbed down before a game. So professional athletics started to see the need for athletic trainers as well, but it very much got its start at the collegiate level. So that original NATA was founded in the late 30s, and with America gone to war, it really kind of fizzled out. By 1945, that first NATA had basically just kind of dried up. It went away. It was a good idea, but colleges weren't competing in sports during that time. The need for the organization was really it was put on hold for a time. In 1947, the very first Conference Athletic Trainers Association was developed, and the idea here was to get these folks together, get them communicating, share this information, so that we could basically help one another out. We're not all trying to reinvent the wheel. So that very first conference occurred June 24th and 25th in 1950 when Kramer sponsored that very first national what they called National Training Clinic. The word athletic training hadn't really been fully adopted just yet. So as I said, the topics at the time, not exactly evidence-based practice. There were only 125 people in attendance. The Kramers used this opportunity to get people together and essentially kind of divide and conquer and improve communication within the now growing, we can't even really call it a profession because it wasn't yet, but this growing group of people all doing the same thing and turn it into a profession. That was really their goal. And I'm sure in the back of their mind, their goal was to get these people loyal to the Kramer company and get them purchasing Kramer products, but we really do owe quite a lot to the Kramer brothers. I don't believe that all of their motivation was strictly influenced by the dollar. Uh, they gave of themselves and gave of their company to see to it that this new idea of an individual assigned to work with a physically active person could actually become a viable job opportunity for them. William Pinky Newell, who was the head athletic trainer at Purdue University, was appointed as the executive secretary, and his entire goal was to gain recognition for the profession, getting colleges other than Purdue and large-scale public institutions to recognize that it's really in their athletes' best interest, and it's in the best interest of the institution to hire someone who can take care of these needs. And so their goal was to advance the profession, and they did that. They created a journal that still exists today in 1956. They adopted a code of ethics that has undergone changes, obviously, but is still in existence. And in 57, they also aligned the NATA with the NCAA and created a symbiotic relationship so that the NCAA recognized that athletic trainers were there and they were there to protect student athletes, and by the same token the NCAA could help champion the cause of the NATA and see to it that member institutions hired ATs. In 1959, the very first formal education program was approved. I believe that was Mankato State University in Minnesota, if I'm remembering that correctly. The organization continued to grow, as did membership. So by 1965, just 15 years later, that 125 members that showed up at that first ever conference reached 1,000. As I said, it was mostly white males before that time. In 1966, Dottie Cohen was the first female member of the NATA. And minorities were also beginning to show interest in the profession, and rightly so, given jobs that appealed to people of all different walks of life. The very first certification exam was given to 14 candidates in Waco in 1970, and we're continuing to see this kind of groundswell of just people doing a job turn into people training for a job and people showing their competency in a job through an exam, and that's precisely what it takes to build a profession. So thankfully for us now, almost 80 years later, 70 years later, we don't have to worry about it justifying ourselves as a profession like these early pioneers did. That's not to say we're exactly where we want to be professionally, but a lot of this hard work has already been done. Okay, Otho Davis, who was at Ohio State, I believe, secured liability insurance for athletic trainers. Prior to that, there was really no professional protection available. He also secured corporate sponsors from Quaker Oats, which owned Gatorade, and Johnson & Johnson. So these sponsorship opportunities allowed the national conference to continue to grow in size, and the venue that hosted it could be a little bit nicer, and there were just a lot of things going on to make sure that this profession was continuing to head in the right direction. Now, along that same time, Texas was the first state to enact a licensure law, and this was before any other state. And in order to be licensed, athletic trainers had to pass a test. They had to have standards of education. There were certain classes they had to take. They also had to commit to an ethics statement in order to be eligible for licensure. In 1972, we saw the very first graduate program. So prior to that, they were all at the bachelor's level. So University of Arizona and Indiana State. So this continues to elevate the perception of the profession to the larger medical community. Prior to that, it was all just bachelor's degrees. In 76, we saw continuing education implemented. This, again, shows our peers within the healthcare system that we're serious about healthcare. We're not just there to provide water or to to do tape jobs. We're an allied healthcare professional. By 1986, membership had swollen to 10,000 members from that first 125. And we see more and more females and minorities getting opportunities and joining the ranks. So that's really the history of athletic training. So we want to shift gears just a little bit and look at the profession itself. Okay, so the first question we have to ask ourselves is, what's it take to be a profession? Okay, so in order to be characterized as a profession, there are really four critical things that any group of people have to show. And the example I give here is we could compare athletic trainers to tarot card readers or to aromatherapists. Okay, is there a credentialing exam for tarot card readers? Not that I'm aware of. Okay, so the first question we ask, is there a specialized common body of knowledge? And in order to answer that question, we have to look at what's being taught. We also need to establish that they do possess professional authority, that the community recognizes the profession and sanctions it, signs off on it essentially, and that there is some sort of regulative code of ethics in place. Now, the process of gaining recognition as an allied healthcare professional actually started way back in those 30s and 40s, but it took a huge step forward in June of 1990 when the American Medical Association recognized athletic training formally for the first time as an allied health profession. Now, around those times, it was necessary to really grow and enhance education for athletic trainers. Prior to that, it was really just an apprenticeship. You went and trained under someone who worked as an athletic trainer, and you became one yourself. You didn't really necessarily have to sit through course after course and do clinical evaluations. It was all just kind of on-the-fly job training. So the Committee on Allied Health Education and Accreditation, or CAHIA, was charged with the responsibility of developing what it meant to be an athletic trainer and what those programs needed to teach. And that was basically regulated by what we call the JRCAT, the Joint Review Committee on Athletic Training. The very first entry-level athletic training programs that were accredited by the JRCAT and CAHIA were approved in 1994. And since that time, we've seen this number grow to over 300 programs. Now, at Texas Tech, the undergrad program is not accredited. It will prepare an potential athletic training student for Texas State licensure, of which a course like this would be one of the requirements. However, completing the program at Tech on main campus wouldn't enable someone to sit for the national certification exam. Along with hours and other coursework, they could take the Texas license exam, and that's different. We'll talk about that in just a minute. In 1996, the Board of Directors adopted an education task force whose job it was to look at athletic training education in general. Now, this internship route, where you took 3 or 4 classes and you did, I think it was either 1,500 or 2,000 hours of observation, was phased out in 2004. Now, at the time, I was a graduate assistant at the University of Arizona, and we had an internship program, and we eventually phased that out. And the reasons for that were many. First of all, the pass rates for internship candidates was significantly lower than it was for curriculum candidates. So at this time in the early 90s on through to 2004, you could go either way. So there are people out there in the world who went to Texas Tech, a non-accredited program, and are certified athletic trainers. However, that time has come and gone. You can't do that anymore. At the Health Sciences Center, on the other hand, we do have an accredited entry-level master's program, so you can attend that and graduate and be nationally certified. 1997 saw the first educators conference. We got our first billing codes in 1999, which was a big step in gaining recognition and getting third-party reimbursement. So in other words, if someone goes to a clinic and they're seen by an athletic trainer, those codes didn't even exist. We couldn't even try to bill. With those codes on the books, it is possible, but we're still struggling with third-party reimbursement in most states. You're not going to get third-party reimbursement from an insurance company for athletic training services rendered. In 2003, we saw the move from JRC-AT to what's now called CAATE, C-A-A-T-E, in 2006. So if you're interested in becoming an athletic trainer, you can go to the CAATE website and see a list of all the accredited programs, of which the TTU HSC program is listed. In 2007, we went to computer-based exams only. Prior to that, there was a practical exam. There was what we call a written sim. But with this movement in education, the expectation is if you're going through an accredited program, then you're being tested in practical examination settings over and over and over again. So there's no need for that to be at the exam. It's all just written and content-based as opposed to skills-based. So currently there are more than 300 undergrad programs that are accredited, and there are more than 30 at the graduate level that are accredited. Now, there is a transition occurring right now so that all of those undergrad programs are either going to have to shut their doors or transition to the graduate level by 2020. So it will no longer be possible for someone to become an athletic trainer with just a bachelor's degree after that time. There are programs currently that exist and those that are in the works that will give certified athletic trainers additional training. So at the HSC, our program is entry level. Someone comes here and they may have studied athletic training at Texas Tech and have a kinesiology degree, but they want to get certified, or maybe they've got a degree in a completely different field. As long as they've got their prereqs, they can do that. There are other master's programs for people who already have their certification, and those are called post-professional programs. So it'll be interesting to see what happens with those, because there really won't be a need at the master's level, because every certified athletic trainer will already have a master's, and it doesn't make a lot of sense to go back and get another master's. So my guess is most of those will be transitioning to the doctoral level, whether that's a PhD or an SCD, still yet to be determined, but that's what's going on. Oops. Okay, these specialty certifications, this really doesn't exist yet, but the NATA is looking at ways to further enhance professional development, making us specialists in things like youth sports or industrial athletic training or any number of specialty fields, and these are all considered post-professional. This would be something you would do after you got certified. Now, the profession of athletic training is really just a component of a larger sports medicine field. I can remember when I was in undergrad, before I even started to study athletic training, if anybody asked me, I would tell them I was going to go to Southern Illinois University and I was going to study sports medicine. Now, that wasn't really true. I didn't know it at the time, but that was inaccurate. I was going to study athletic training. Sports medicine, there's really not a major in that, especially at the undergrad level. Sports medicine is an umbrella term. It encompasses athletic trainers, it encompasses physicians, it can include strength coaches, nutritionists, sports psychologists, any number of people who work to meet the needs of that athlete or physically active person. Okay, so that field of sports medicine isn't really something you major in. It is, there are physicians who are sports medicine trained, but certainly there are no 19-year-old college sophomores who are majoring in sports medicine, regardless of what I might have said at that time. Okay, so we've seen these professional sports medicine organizations grow over the years. The NSCA is one that many of you may be familiar with. This is more related to strength and conditioning and sports performance. This one is one I'm a member of. A lot of athletic trainers see that natural synergy between what we do on the prevention side as athletic trainers and what we can do on the performance side as strength and conditioning specialists or certified personal trainers. So that's kind of a natural fit. You notice, though, they've only been around since 1978. So athletic training as a profession, I always like to say we're a step or two behind where PT is. Physical therapy got its start before we did, and we've always been kind of running to catch up. And behind us, kind of in the same boat, is the NSCA. And it's not to say one's better than the other, it's just to say that the professions are of different ages, and PT got a jump start on all the rest of us, and strength and conditioning really got the last start on us. So you'll see a lot of times professional organizations kind of follow the pattern that those that preceded them did, and that's very much what happened in the case of athletic training. Now, where do we work today? Well, traditional setting of practice included primarily colleges, as we said in our history lesson. That's really where it got its start, but it didn't take long for that to kind of trickle down into the high school level. Certified ATs today work in professional sports. They can work in hospitals. They work in rehabilitation clinics. I've personally worked in every setting there is listed here, with the exception of military. Equipment, reps, whether that be for surgical durable goods, braces, things of that nature. And then physician extenders, where the AT works in the clinic and really just increases the capacity of patients that can be seen in that clinic, and it can be very cost effective for the physician to hire an athletic trainer or two just to increase the capability of that office, make things move a little faster and more smoothly. Now, we've seen a number of things change as we've grown out of this model of just being in the college setting to all of these different areas of practice. We've really enhanced our recognition as healthcare providers. We have increased that diversity of practice settings pretty substantially, and now we have practice acts in almost every state that protect what we do. So if you come to Texas and you claim to be a trainer and you don't have any background at all, you don't have any education, you just watch some YouTube videos, then the law can come after you. You can be prosecuted for holding yourself out to be an athletic trainer without the credentials. Now, when we talked about a profession, we said, aromatherapy. I'm just making this up. So if you're an aromatherapist, I apologize. But anybody can claim to be that. And for that matter, even things like personal training. There's no practice act that I'm aware of in the state of Texas that protects personal training. So there can be dramatic differences between one personal trainer to the next because there's no regulation there. Now, we have had some pretty significant struggles to get third-party reimbursement, and that's frankly holding back job growth in the profession, and you won't see the profession explode in terms of job availabilities as long as that continues. Now, there's obviously some resistance for that to happen from some other professions that are kind of sort of like what we do. So if an athletic trainer works in a clinic to do rehab and the insurance company can reimburse for those services, then it makes sense to hire ATs. If they can't and they have to work as a PT aide in order to bill for that, then maybe it doesn't make sense to hire them. So it'll be interesting to see what happens with this notion of third-party reimbursement and whether or not that ever actually happens. So what we see today, we're not really a member of the coaching staff. We're a member of the healthcare team, and that's important. When I hired in at an institution in Virginia, a private school, my job was actually paid for out of the football staff. This was a Division I university, and the individual that I reported to was the head football coach. And that meant I got a bigger salary than some of the other athletic trainers who were just through the athletic department. But it also created some potential issues. Now, it's the coach's job to win football games. It's the athletic trainer's job to take care of the athletes no matter what. And there are times when those needs can kind of collide. So we work to get that changed so that my direct supervisor was the athletics director, not the football coach. And that's important. I'm not a coach. I'm going to do everything I can to protect and help that athlete compete as safely and as effectively as possible. But if it comes down to a decision between winning the game and losing the game, someone playing and someone not playing, and that being the decision, I want to make sure I'm making that decision as a healthcare provider who is advocating for my patient, not as a coach who's trying to win a game. Okay. We've also seen athletic training grow into areas we never even dreamed of when the first few positions in the profession got their start. So NASCAR, performing arts. Just not long ago we had a Cirque du Soleil show come through, and their medical staff met with our students. Totally cool. They travel from city to city, and there are athletic trainers and physical therapists that treat and evaluate and rehabilitate those performers who are unquestionably athletic. We've also seen athletic trainers in the military. A former student of mine works with the Navy SEALs, NASA working with the astronaut crew, law enforcement, prisons. I mean, basically anywhere there are people who are physically active, the skill set of the athletic trainer is a pretty good fit, frankly, because we approach evaluation, prevention, treatment a little bit more proactively. We're on the prevention side. If you think of healthcare as a continuum, and on one end you've got people who are involved in fitness and ensuring that injuries and illness are less likely to occur. That's what's called upstream care. Downstream care, on the other hand, are folks that are reacting to injury or illness. The insurance companies have started to realize that upstream care is a lot cheaper. Not only does it lead to a better lifestyle, which is admirable in and of itself, it's far less expensive to keep someone from getting injured than it is to get them an MRI and to have them get surgery and those kinds of things. So our model of healthcare has always been prevention minded. It's not we get a referral from somebody and we treat an athlete. It's we try to prevent injuries before they occur. So it's a great fit for kind of that next step in the healthcare system. But because the profession has changed so dramatically, and it's not just a few athletic trainers in college, it is now people in all walks of life, all different settings professionally, then we have to educate those individuals differently. So we've seen that change as well. We don't just give medical care to athletes or those who are only injured during physical activity. As I said, I worked in an industrial setting. I worked at a tire plant. There weren't a lot of athletes there, that I would call athletes, but they were physically active. And this physical activity wasn't playing a softball game. It was lifting a tire and putting it on a pallet, or running a machine. So as such, we've kind of distanced ourselves from coaching and from this athletic model more to clinical health care. So and you'll still hear me refer to this, and it's just an old habit. You'll hear me refer to the people that I care for as athletes. The preferred term is patient or client, and you'll hear a lot of people talk about the training room, and it's actually much preferred to talk about it as the clinic or the facility as opposed to the quote-unquote training room. Now, along with this, we've also changed some definitions around the profession too. So the term occupational athlete you'll see from time to time. They are involved in strenuous, demanding, or repetitive physical activity. In some states, the Practice Act for physical therapy is such that an athletic trainer can't render care to someone who is not a quote-unquote athlete. So that was a roadblock to getting licensure in those states. So we've worked to try to change that. Okay, so there's lots that our skill set is well suited for that we can do in an industrial setting that can help employees. Okay, so instructing them on how to make their workplace safer, ergonomics, how to lift heavy loads appropriately, how to stretch and to cope with the physical demand of the job. There are a lot of things that our skill set working with athletes really translates over into average non-athletic population very, very well. And prevention is key. We are definitely on that upstream side of the healthcare continuum. So when we work with physically active folks, this can be athletes, this can be recreational or competitive activities, whether they're athletic or not. Can require physical skills, utilize strength, power, endurance, speed, flexibility, range of motion, agility. All those things are well suited to our skill set in primarily musculoskeletal stuff, but increasingly so general medical things too. So we manage injury prevention, and we make sure that we refer what we need to refer and we treat what we need to treat. We deal with that patient from the inception of the injury until that athlete returns to full competition in many situations. So for example, if I'm a physical therapist working in a clinic, chances are my patient was injured. They were probably evaluated at some point by a primary care physician, who then referred them probably to an orthopedist, who either did surgery or prescribed a medication or just prescribed physical therapy. And now I see them and I figure out how to render care. So that's at minimum 2 other medical professionals that have already seen the patient, rendered care, and all this time, days and even weeks have gone by, and my patient's still in pain. Okay, that is, in my personal opinion, and I hope no one takes offense to this, but that's a slow, inefficient model of healthcare. That's not really reflective of how I'd like to see things really unfold. On the flip side of that, an athletic trainer working with the Texas Tech football team, they are at practice every day. An athlete shows up with a sore hamstring. That athletic trainer is there to stretch, to evaluate. They're going to be present during workouts. They're going to be there from the moment that injury occurs or shortly thereafter, and they're going to decide what to do, and they're going to get to render care. Now, again, I'm not saying one profession is better than another, but for myself as a clinician, I know which I would pick, and I know, in all actuality, I know which one my physical therapist colleagues would probably prefer, and that's to be there and to get to evaluate that injury firsthand when it first occurs. So in a lot of ways, we really are blessed in how we get to deliver healthcare. To me, it's a far more efficient model that will ensure better results. Okay. Now, the Board of Certification has divided up roles and responsibilities of what it means to be an athletic trainer into what they call their certification domains. Okay, so this is what it means to be an athletic trainer. We're intimately involved in prevention, so we want to keep that injury from happening to begin with. Then if it does occur, we evaluate it and we make a diagnosis. We provide care right away. Then we provide ongoing care after that injury occurs, treatment, rehab, reconditioning. We also are responsible for making sure that all aspects of care are appropriate, and we refer as needed, and that's administration. And then professional responsibilities ensures that we keep our certification current. We stay up to date on all the latest practices and research. Okay, so under this big umbrella of prevention, a lot of things fall here. Okay, we ensure a safe environment. We check the field prior to practice. If it's an industrial setting, I'm going to look at the workplaces and make sure that all the workstations are ergonomically sound. In athletics, we do pre-participation physicals. At the industrial level, we did pre-employment screening. We can assist with the development of training and conditioning programs. Now, that's not to say that every athletic trainer is qualified to pull together off-season conditioning. That's usually going to be a duty issued to the strength conditioning coach, but we certainly have training in this area, and we should be able to work in concert with those folks. We make sure that protective equipment is fit properly. We also can provide, again, we're not dietitians, we're not licensed as dietitians, but we can provide counseling on diet and lifestyle choices, ensure appropriate medication use, whether that be OTC or if they've got a prescription med, we can provide counseling if the athlete or if the patient has questions, and discourage substance abuse. Now, regarding evaluation and diagnosis, it's our job to be able to recognize the nature and the extent of an injury, whether or not we can, what EMTs often refer to as stay and play or load and go. This involves on-field evaluation skills that are quick and decisive, as well as off-field evaluation skills where maybe it takes a little more time and we have to be more thorough in our decision-making process in order to figure out what's going on and render the best care. So in order to do that, we have to understand how injuries and illnesses occur, how the injury process unfolds, and we have to know when to refer for specialized medical care or supportive services. Immediate care also involves first aid skills, administering appropriate first aid, CPR, AED, what are referred to as emergency action plans, and activating that in a timely fashion. Once an injury has been evaluated and we've made a diagnosis and we have taken care of that emergency situation, then being able to treat and rehabilitate that injury comes into effect. So designing preventative training systems so that we can keep those injuries from occurring, and then implementing those along over time so that rehab occurs. We supervise those rehab programs, make sure that they're being compliant, and we incorporate therapeutic modalities. We'll talk about all this in turn throughout the course of the semester, but just so you know what the profession involves, here's where it is. Organization and administration, that domain involves record keeping. If we didn't write it down, we didn't do it as far as the courts are concerned. So making sure that we're up to date on all of our record keeping is critical. We also have to order supplies and equipment. We have to establish policies and procedures, hire, fire, supervise personnel. That's all part of the job. Professionally, we're all teachers. Okay, most athletic trainers that you talk to are more than willing to let you look over their shoulder or shadow them or otherwise teach you. We also have to maintain our credentials through continuing education. We are not licensed professional counselors, but we do serve as usually the patient's first line of entrance into the healthcare system. Especially at the high school level, it seems like a lot of kids don't get adequate health care. Their parents aren't insured, but they can go see the athletic trainer at their school for free pretty much anytime they want. So recognizing psychological issues, if a student's depressed or if they are having issues at school, that we may be the first people to notice that, or the first people that they confide in. So it's important that we know what to do in those circumstances. As a researcher, increasingly so, our treatments need to be rooted in evidence, and that's a great thing. For far too long, in my opinion, our profession has just done what the generation before us did without really understanding how or why or even if it worked. And now we are shifted to what's called evidence-based practice, so that if I'm going to apply a tape job or a brace, or if I'm going to recommend anything, whether it's a particular diet or a supplement, then that's rooted in evidence, and I can justify any recommendation I make or whatever practice I use based on the available science, not just opinion. What's it take to be an athletic trainer? It takes lots of stamina and ability to adapt. I often say that a lot of athletic trainers work in jobs where they've got an hour's worth of work stuffed into a 14-hour day. When you need to be there, there's a lot going on, and there may be days where it feels like you don't have time to think or eat or anything else. You're all about what's going on in that instance. When you get into some of the more non-traditional athletic training settings that are more like a normal job, for instance working in an industrial setting, it's more of a 9 to 5. So that's maybe not as important, but in the traditional AT setting, you definitely need to be able to work long hours and lots of days without days off. Empathy is critical. Basically everybody that comes to you has a problem, and if you don't have empathy, you're not going to be able to connect with them. You're not going to develop that rapport with them. Sense of humor can really lay the groundwork for good patient clinician interaction. So that's critical. Communication is absolutely essential. You're communicating with the athlete, with the coaches, with the parents, with the medical professionals, with the administrators. You're kind of at the center of this, and it's your job to be the conductor that ensures that what the physician says is being carried out in practice as far as limitations, or what the coach says about an athlete's performance. If, for instance, I worked gymnastics my first year in as a graduate assistant, and I'd only watched gymnastics on the Olympics. I didn't know much about the sport. So in order for me to really understand what was going wrong, sometimes I had to ask my coach. I couldn't tell. Okay, she can't hit that kip cast handstand to vertical. That's a problem. That's not her. I didn't have the eye that would have caught that, but they did. And being able to communicate that to our team physician to understand how that was manifesting, that was shoulder pain, and that's why her shoulder pain was the reason she couldn't do that. So that's important. You need to be intellectually curious. It's a healthcare profession, and as such, everything about it changes. It's safe to say that what I absolutely knew coming out of college to be true, much of that's been called into question or even completely overturned. Okay, for instance, the use of modalities, electrical stim and ice, ultrasound. That's about all we did when I was first coming out. And now the big focus is on manual therapy, doing joint mobilizations and corrective exercise. And people really don't utilize modalities like they once did. If I was content with my knowledge, it wouldn't take me long to be out of date and to be ineffective as a clinician. You absolutely have to be ethical. And that holds true in all aspects of life. But if you're the head athletic trainer at a major Division I institution, there are plenty of people who bet money on the games that your athletes are participating in. There are no shortage of people who want to know what you know. And we have to recognize that as healthcare professionals, we are bound by ethical standards that keep us out of that kind of trouble. And lastly, professional memberships, whether that's the NATA or other related organizations, National Sports Medicine Association, the International Youth Conditioning Association. Sorry, I said National Sports Medicine Association. What I meant to say was the National Academy of Sports Medicine, NASM. NSCA, which we've already talked about. Those are all, they're orbiting around similar areas of professionalism, and being involved in those can make us a better clinician. Now, as we alluded to previously, the major concern on the part of the AT is on the injured patient. It's not on winning the game. Decisions that impact the patient are our decisions, and it's our job to be their advocate. And sometimes that's even contrary to what they would want. I've dealt with plenty of athletes that wanted to be put back in the game, but I knew that it wasn't safe for that to happen. Okay, so the injured patient needs to be made aware of how, when, and why that dictates the course of their rehab. They need to, as best they can, to the extent they care, be educated about their injury or their illness and how that's probably going to unfold. And if that changes along the way, they deserve to know that. We don't serve to conceal truths or otherwise cover for, maybe a coach who wants a scholarship back. They offer an athlete a scholarship. There's only so many they can give, and once they got that kid to campus, they found out he wasn't as good as they thought he was. So, hey, can we get a medical DQ for him? That's not our job. Our job is to render care to the best of our ability. So we want to educate that patient about injury prevention and management. Help them to take ownership. Okay, when I'm working at the college or the high school level, I'm not just dealing with an athlete. I'm dealing with a young person. And that young person is learning what it means to be an adult. So if I can teach them how their high-risk behaviors are impacting what they do. Here's another example. When I worked with gymnastics, almost all the girls on the team smoked cigarettes. And that was crazy to me. I thought, these are elite-level athletes. They're going to eat all the best foods, and they're going to do all the right things. and that couldn't have been further from the truth. Nicotine was an appetite suppressant. They used it to help reduce body weight. Gymnastics is an aesthetic sport, and how you look in a leotard can impact your score. So my job was to provide care for them, and it wasn't to be a harping parent, but I also owed it to them. If they have a stress fracture and they're consuming alcohol and smoking cigarettes, their healing's going to be slowed. Okay, so that impact is broader than just helping them to maintain body weight. I also want to give them instructions regarding training and conditioning. You see this a lot of times here in West Texas. I might cover a Friday night football game, but I'm not there through the week. I'm just there for emergency evaluation, assessment, care, but I'm not there for the day-to-day delivery of health care. In those cases, a lot of times I'll prepare a home exercise program or an exercise program that can be done at school that can help that athlete. Say they've had problems with shoulder instability or ankle sprains. I can prepare them some exercises that are going to protect them come game day or come practice day. With the parents, this can be a challenge at times, quite honestly. It's one of the reasons I never really had an interest in working full-time at the high school level. We must keep the parents informed. These athletes, these patients are underage, so especially in that secondary school setting, but even in the college setting, you may have an 18-year-old, 17-year-old college freshman, and the parents are involved in that decision-making process. Insurance plans may dictate care. Okay, whoever their primary care physician is, that may be where you have to send them so that any referrals would be covered under their insurance. We also have to be aware of HIPAA. This is the Health Insurance Portability and Accountability Act. This regulates how we can share or disseminate health information. Basically, if a person has a reason to have access to that person's medical care, if I refer a patient to a general physician, then I have the right to disclose my findings. On the other hand, if I don't have any reason to disclose, then I could face stiff penalties for violating confidentiality. So pretty much anytime you go to the doctor, you're going to get a patient privacy standards, and you're going to sign a form that says who you will allow your records to be seen by and whatnot, and that's all because of HIPAA regulations. Okay, the AT works under the direct supervision of a physician. Now, that doesn't mean a physician is there looking over my shoulder all the time, but ultimately if I'm working as a certified athletic trainer, there is a team physician in place that is essentially signing off on what I do. That physician can be more or less involved depending on how confident they are in the athletic trainer. Sometimes you'll never see that physician. I've worked in lots of settings where we only saw the physician when an athlete needed to be seen. It wasn't like they would just pop in and see how they were doing. They weren't actively supervising us per se. But the physician and the AT absolutely have to be able to work together. Here in Lubbock, one of the larger groups is Lubbock Sports Medicine, and they hire a lot of athletic trainers, and those athletic trainers will report to the physicians over there. The philosophies really need to be similar. I interviewed for a job at a major D1 school one time, and it was pretty clear that the team physician was really there to just do whatever the head football coach wanted. And it was very clear that if I needed to hold somebody out, if I made a decision, that wasn't necessarily going to be upheld or supported up through the administration. So that can make for a very difficult situation for you as a professional. If you and the team physician have a similar approach, then that's going to minimize discrepancies and inconsistencies. The physician is responsible for compiling those medical histories during the physical exams. Lots of times that's going to be carried out by the athletic trainer, and the physician's just going to sign off on it, but not always. Everybody's a little different. The physician decides on disqualifications. We'll talk about that a little bit later in the semester. They can attend practices and games, and generally they need to have a commitment to the sport and to the athlete. That team physician can also serve as a academic program medical director who helps steer the curriculum. However, the faculty deem it best, and they can provide some input into the educational content and provide programmatic instruction. With the coach, lots of times this can be a challenge too, depending on the coach you're working with. The coach has to understand the role of all the individuals in the team, as does the athletic trainer. They need to understand the limits of their ability. One of my former students worked at a community college, and she walked in one day and a coach was delivering an ultrasound to one of his athletes on the track team. That's not really their job, and it's not within their scope of practice to be doing that, so that makes for a difficult situation. Ultimately, it's the coach's responsibility to prevent injury, making sure that athletes of comparable skill levels are paired with one another, that drills are safe, that even equipment is up to standard, it's been inspected, that kind of thing, and that the athlete's gone through appropriate conditioning. We've seen a big change in that regard in how high school preseason practices have gone. In recent years, Texas has outlawed two-a-days. You can't have multiple practices on the same day. And that basically takes the decision-making process out of the coach's hand, and it's now become law. So we have to comply with that. Coach has to be aware of the risks associated with the sport, provide training and equipment. Ideally, they should be certified in CPR and first aid. Most districts will now require that. They need to know the skills, the techniques, environmental factors associated with the sport. So working with a good coach, a lot of times they'll be a great resource for you. You know, if a baseball player has a shoulder injury, I've watched enough baseball that I could probably catch that now, but early in my career I wouldn't have. Okay, so I leaned heavily on the pitching coach. Okay, what's different about their delivery? Their eye is trained to see that, whereas yours might not. So the more cooperative this relationship can be, the better it is. When we refer out, we need to be aware of who is available. That patient may require special treatment outside of the quote-unquote traditional sports medicine team. So who's in our community that can help us? Usually the AT and the team physician will consult, and they'll refer accordingly, whether that's to a nutritionist or a counselor or a dentist, or take your pick. Okay, so state regulation in athletic training. Pretty much every state except California at this point has some form of regulation, and California has been working on it for what seems like forever. Hopefully that will change relatively soon. But these laws and statutes govern who can claim to be an athletic trainer, what they can do when they're working as an athletic trainer, and that took some time to get in place. Okay, during the 70s, the NATA realized that we needed to get this done. Okay, and this actually needs to be updated. It's now 49 of the 50 states. Hawaii has since enacted some sort of regulatory statute. We're still waiting on California. Generally speaking, licensure is going to be our best bet. Okay, so if you want to be an orthopedic surgeon, you're going to be licensed as a physician in that state. If you want to work as a physical therapist, you're going to be licensed as a physical therapist in that state. If your dream and your goal is to manufacture pencils at a local manufacturing company, you don't need to be licensed to do that. So not every job is regulated by licensure. And basically, what dictates what's regulated by licensure and what isn't is what do we need to protect the public for or from? What do we need to ensure that the people who do this meet certain qualifications? So this limits the practice of AT to those who have met those minimal requirements. And here in Texas, that basically means you've done hours, you've taken some classes. Most other places, it means you're nationally certified. This limits the number of people who can perform those functions, and this is the most restrictive of all. And that might sound bad, but it's actually a good thing. Okay, if we're now saying you need a master's degree to practice as an athletic trainer, then we want this form of regulation because it says you can practice, but at the same time it says that your kid brother who never graduated from high school can't claim to be an athletic trainer, because when that's allowed to occur, it devalues the entire profession. Okay, if everyone could claim to be an athletic trainer, then schools wouldn't really see the benefit or the value in compensating you or hiring you, even though you've gone through years of training and spent thousands of dollars to get there. Certification is another form of state regulation. States grant title protection. In other words, you can claim to be an athletic trainer as long as you're certified rather. Those who don't have certification can still do what you do, but they can't claim that title. So I've been places where the strength coach might do a lot of the things that the AT otherwise would do. As long as they don't call themselves an athletic trainer in those states, they're okay. And then registration is one of the, frankly, the forms of regulation that has the least amount of teeth to it, so to speak. They can practice athletic training, they can register on a list in that state, they pay a fee. It doesn't necessarily say anything about competency. And then in other places it's exempt, and this basically just says that they're probably going to look at it again in the future. Okay, it allows them to practice athletic training despite the fact that they don't comply with they don't comply or interfere with the practice acts of other regulated professions. Okay, so in the future, we're really going to see growth in a number of areas. I think physician extender in particular is going to continue to grow. If a physician can hire an athletic trainer for $50,000 or $60,000 a year and increase the capacity of their clinic by 20% and bring in an extra, $500,000, $1 million, then would you spend $50,000 to make them an extra million? It's a no-brainer. Okay, the military will continue to grow. Our skill set is very well suited for that area because the military is young. They tend to be athletic. They're definitely physically active, and that's just kind of right in our wheelhouse. Industrial setting is another that will continue to grow because of our upstream preventative model. We're really well suited for that and the fitness and wellness industry. Third-party reimbursement, as I said, is a challenge. International recognition is another challenge. Here at the HSC, we've got a number of international students, and there's really not a whole lot for them to go back to. Japan and Canada being two exceptions. Most other countries in the world, there's really not a lot in terms of regulation. There is now a World Federation of Athletic Training and Therapy, but it is pretty heavily populated with Canadian and American contingents. And then we're constantly looking at how to make athletic training education better. As I said, we're transitioning to entry-level masters and phasing out bachelor's degree programs. There will be changes in our post-professional offerings as well. All right, well, that's it for this portion of week 1. All we have left is legal concerns and insurance issues.